presentation. Before starting the presentation, I would like to thank my mentors, that Professor Dr. Kumudni Sharma ma'am and Professor Dr. Vikas Kanodia sir, under whom I have done my senior residency and under whom I have learned some basic knowledge about the neuro-ophthalmology. Thank you, sir. Thank you, sir and ma'am. So my topic of discussion is case-based discussion. It is the last topic in this session. So as ma'am and sir both have reinforced that there is very large importance of imaging, both imaging and both interpretation of the imaging. So it plays a very pivotal role in diagnosing the case, and beside this, a very careful clinical history. So on this note, I start the presentation. So my first case is a 14-year-old boy which was sent from neurosurgery for pre-operative neuro-ophthalmic evaluation with diagnosis of cavernous sinus hemangioma. On history, he complained of double vision for 2 months, and on a very careful clinical history, he gave a history of a boil at left angle of mouth with cellulitis on left side of the face, which was 4 months back. On examination, patient had right esotropia. The vision was normal in both the eyes. Ocular motility was, there was abduction restriction in the right. Pupil was normal size and normal reaction in both the eyes. Fundus was normal. Field was within normal limits. And rest of the systemic examination was normal. MRI report done outside. There was a cellular mass, as you can see here, with contrast enhancement and extension in right cavernous sinus with internal carotid artery being pushed peripherally. So the diagnosis of cavernous hemangioma was made. But when the MRI was re-evaluated, we found that on T2 weighted MRI, it was a sac-like outpouching. If anyone has seen the cavernous hemangioma MRI, there is a homogeneous contrast enhancement. Here you can see that it is not homogeneous contrast enhancement. What it is there is a peripheral hyperintense signal. This is peripheral hyperintense signal, then hypointense signal, and then again hyperintense signal, which was suggestive of a turbulent flow in the sac. So post-contrast MRI also shows intense enhancement suggestive of mycotic aneurysm of right cavernous sinus of internal carotid artery. DSA also, digital subtraction angiography, also confirmed the same. Blood culture was negative, but on the hemogram there was increased leukocytosis, increased ESR and increased CRP, which pointed towards a infective pathology. Patient underwent parent vessel occlusion of the right internal carotid artery with vascular plug of vitreous and upper cervical part. On post-occlusion, there was no flow, and on follow-up, right 6 nerve palsy is improving. So it was a very out-of-the-box case, as mycotic aneurysm, we all know, is a dilatation of the artery due to damage of the vessel wall by an infection. It is also called as infected aneurysm. This aneurysm is very dangerous because it has a high tendency to rupture, and a very high index of suspicion is required to make the diagnosis. So what was the catch in this? The MRI finding of the turbulent flow in the lesion helped in making the diagnosis of mycotic aneurysm. And mycotic aneurysm is also a disease of the elderly. It mainly presents around 65 years of age. There may be history of intravenous drug abuse. There may be a history of immunocompromised state or a history of endocarditis. And very lastly, the cerebral arteries are involved. Most commonly, femoral arteries, aorta and splanchnic arteries are involved. So it was a very atypical case, which was diagnosed on high index of suspicion and a good radiological evaluation. Now coming to the case 2, a 33-year-old male patient presented to a local doctor with complaints of to a local ophthalmologist with complaints of sudden onset diminution of vision and mild pain in right eye for 2 days. His vision was PL positive in right eye and 6/9 in left eye. He was diagnosed as a case of retrobulbar neuritis and was started on injection methylprednisolone followed by oral steroids along with oral multivitamins. But patient was not very symptomatically better, so he consulted our neuro-ophthalmology department. On examination here, the vision has improved to 6/18, and in left eye, the vision was 6/9. But we found other findings also. There was no history of nausea, vomiting, headache, diplopia, or any other neurological complaints. Pupil in right eye show RAPD with sluggish reaction to light. Color vision was impaired in right eye, whereas in left eye it was normal. Fundus examination revealed pallor in right eye, but there was also temporal pallor present in left eye also. Perimetry here revealed bitemporal hemianopia with central scotoma in right eye. VP showed normal latency in both eyes. MRI on initial examination revealed findings suggestive of hemorrhage in suprasellar region on right, tracking along right optic tract at an institute. As can be seen in this picture, there is hyperintensity in suprasellar region on right and along right optic tract suggestive of this. It is suggestive of hemorrhage in suprasellar region and along right optic tract fibers. So, when the follow-up MRI at our institute showed minimal patchy enhancement in a small space-occupying lesion in relation to optic chiasma on right with partially resolved bleed, suggestive of a cavernous angioma with bleed, which is also known as chiasmal apoplexy. Patient was referred to neurosurgery for surgical intervention. So this is the hemorrhage with the T2 images show heterointense lobulated lesion in the region of optic chiasma. This suprasellar region more towards right with peripheral T2 hyperintense rim. So it was a case of chiasmal apoplexy which was misdiagnosed as optic neuritis. Chiasmal apoplexy is a very uncommon clinical syndrome. It consists of a triad of abrupt frontal retrobulbar headache, abrupt visual loss, and chiasmal field defect. The source of hemorrhage is either a cavernous malformation or an AV malformation of the optic chiasma. So, not only this case, earlier also there have been cases which have been presented as misdiagnosed as optic neuritis, as in a study conducted by Peterson et al. 3 patients were misdiagnosed as optic neuritis patient. But after taking a brain CT, pituitary adenoma together with the formation of cyst was detected in patients. So the correct diagnosis, who had been incorrectly diagnosed as optic neuritis, was pituitary apoplexy. So if optic neuritis patient presents with bilateral presentation, if there is very profound loss of vision, if there is absence of pain prior to vision loss, together with atypical neurological findings, one should search for an alternative etiology. Thank you for your patient listening.